bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive. Hello, everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres, and today we're going to be talking about the ABCs of DCD, and DCD is Developmental Coordination Disorder, and by the looks of the registration, that's not I didn't need to tell anybody that. It's become a very popular webinar, more than 200, almost 300 registrants for this webinar, so certainly a very hot topic that we've managed to pick, somewhat surprisingly, as I wasn't sure there'd be that much broad interest across the community, but clearly this is an issue that people are struggling with. As Dr. Jill Zwicker, our presenter, has mentioned in the description and in her bio, she considers this an unrecognized disorder, and apparently lots of people are now recognizing it and now looking for some input as to what they should be doing about this disorder now that they have recognized it. So we will be joined, hopefully I'm going to be joined today by Dr. Gail Andrew, who's often my co-host on these rehab-focused topics. Gail is one of the co-chairs of the CINSER KT and Research Committee, and CINSER being the Canadian Network of Child and Youth Rehab, which is the network of CAFC members that are interested in rehabilitation services. We are having a little bit of audio trouble with her, but hopefully by the time we get to the discussion period, Gail will be able to join us, and we'll be able to have her great input as always. So without any further ado, it's my pleasure to introduce Dr. Jill Zwicker, who will be our presenter for today. Jill is an assistant professor in the Department of Occupational Science and Occupational Therapy at the University of British Columbia, and she holds appointments at a number of organizations, including BC Children's Research Institute, clinician scientist at Sunny Hill Health Centre for Children. She's with the Kids Brain Health Network, which is formerly NeuroDevNet, for those of you who aren't aware of the change, as well as CanChild and others. She has established the first research-integrated diagnostic clinic for DCD in Canada to facilitate diagnosis of this under-recognized disorder, and lots of other experience with DCD, so truly an expert. So without any further ado, it's my pleasure to hand the virtual podium over to Dr. Jill Zwicker.
Thank you very much, Doug, and it's a pleasure to have the opportunity to present today, especially about something that I'm very passionate about, and that's children with developmental coordination disorder. So thank you very much for the opportunity. What I thought I'd do today is, I called it the ABCs of DCD, and really what I hope by the end of today that you'll become more aware of what DCD is and how it affects children, and more importantly, how to assess and diagnose the condition. Secondly, I hope to just highlight some of how the brain might be impacted in DCD, and then finally to become more aware of the research clinic that I've established, and hopefully others may be interested in doing the same. So just to start off with awareness and assessment of DCD, as most of you probably know, DCD is a developmental disorder present from birth, but it's often not recognized until the child reaches school age. That being said, there has been increasing efforts to try and identify children much earlier than school age, and we have had some efforts to identify children in preschool, but some recent work that I've done shows that even from as young as 4 months of age, children who ultimately go on to develop DCD perform more poorly than their typically developing peers. The DCD it is of unknown etiology. We do suspect that there's central nervous system pathology, which we'll talk about in a moment. But the disorder significantly interferes with a child's ability to both perform and learn motor skills. And this could affect the children just in fine motor skills, such as with using a knife and fork or printing, tying their shoes, just with gross motor skills, such as hopping, playing sports, riding a bicycle, and so on. Or it can affect children in both fine and gross motor skills. Despite it being under-recognized, it's actually a very common disorder and affects 5 to 6% of school-age children. And if we put that into the latest Canadian StatsCan population data and the average classroom size, that means that there's 1 to 2 children who would meet the criteria for DCD in every Canadian classroom. So it is quite significant, but I can guarantee you that many of these children would not be diagnosed with the disorder and thus may not be receiving the supports that they need. There are 4 diagnostic criteria for DCD in the Diagnostic and Statistical Manual. The first is that the motor skills are substantially below what you would expect for the child's chronological age and their opportunity for learning and use. Secondly, these motor skill deficits must significantly and persistently interfere with activities of daily living and may impact school productivity, pre-vocational and vocational activities, leisure, and or play. So we're not talking about kids at the lower end of normal that may be a little bit clumsy but can happily go on with their life. These children have significant difficulties in their daily life. Thirdly, the symptoms appear in the early developmental period, so there are some warning signs that the child might be at risk of DCD. And finally, that the motor skill deficits are not better explained by other diagnoses, other neurological conditions, intellectual disability, visual impairment, and so on. And we'll revisit these criteria a little bit later in the presentation when I'm talking about assessing children for the disorder. Aside from the difficulties with performing and learning motor skills, there are other physical concerns with this condition in that children with DCD tend to avoid physical activity and lead a more sedentary lifestyle than peers without DCD. This also places them at increased risk for obesity and cardiovascular disease. And people used to think that children with DCD would outgrow their difficulties, but more and more longitudinal research has shown that these difficulties do tend to persist into adolescence and adulthood. The functional impact of the disorder may lessen over time, but the underlying motor difficulty remains. But what I really want to point out is that DCD is much more than a motor impairment. And in fact, we have a host of data to show that children with DCD experience many secondary psychosocial difficulties. And these include difficulties with academic and behavioral difficulties in the classroom. They report lower perceived competence not only in physical activities, but in cognitive and social activities as well. Concerningly, there's higher levels of anxiety, depression, and loneliness, and they experience greater social rejection, teasing, and bullying. As a result, they have lower self-esteem, quality of life, and life satisfaction. And recall that this tends to persist into adulthood, so it's not just a childhood disorder. And so given this information, we can really consider DCD a chronic health condition. It affects multiple domains over a long period of time. DCD often does not occur alone, and in fact, up to 50% of children with DCD may meet the diagnostic criteria for attention deficit hyperactivity disorder. So there's about a 50% overlap, but DCD also frequently co-occurs with learning disabilities and speech and language difficulties as well. So that's at about 25 to 30% overlap. And an important distinction, now children with autism on the autism spectrum may have a co-occurring DCD diagnosis if they have motor difficulties that interfere with their daily living. Since this has only been permitted since the introduction of DSM-5 in 2013, we don't have a lot of data on the co-occurrence, but we do know that about 50% of children with ASD may have motor difficulties, which may in fact be co-occurrence of DCD. And the final thing I want to note is that DCD is much more common in preterm born children. And in fact, children born very preterm, less than 32 weeks gestational age, are 6 to 8 times more likely to develop DCD compared to full-term born children. And in fact, even late preterm babies, so 34 to 36 weeks, have a 3 to 4 times more likelihood of DCD as well. Up to 50% of infants born preterm may meet the criteria, and we've started to look at possible predictors for this in this high-risk population, and we know that male sex, low birth weight, and exposure to postnatal steroids are some predictors of DCD. And we're currently looking at a cohort of preterm born children who are now age 8, coming back, those that have a diagnosis of DCD compared to children who don't. And we have neonatal brain scans, so we can look back in the neonatal period and their time during the NICU and what exposures they had to look at other possible predictors of the disorder. When we get a chance to look at predictors, we can also then hopefully inform opportunities to prevent the disorder. So as I said, I wanted to revisit the diagnostic criteria to get to my other A, which is assessment of these children. And so recall the first criteria is that the acquisition of coordinated motor skills is substantially below what would be expected. And this is normally assessed by an occupational therapist or physical therapist with any standardized motor test, but the most commonly used one is the Movement Assessment Battery for Children version 2. And using the European Academy of Childhood Disabilities guidelines, a cutoff score of less than the 16th percentile, or a standard score less than or equal to 7, is the cutoff score for this criterion, except for younger children. Ages 3 to 5, it's recommended to use this more stringent cutoff of the less than or equal to the 5th percentile. Something that's new in these guidelines is that if a child scores less than the 5th percentile in one domain, whether that be fine motor skills or balance, for instance, but they score overall higher on the movement ABC, they could still have a DCD diagnosis if the other diagnostic criteria are met. I have to say this hasn't come up very frequently in the DCD clinic to use this criterion, but it's something I just wanted to point out. So that this would be a child that might be more affected in one domain over the other. Secondly, the motor skill deficits must have shown some impact in daily life, and there are a few tools that are available to help determine this. One is a developmental coordination disorder questionnaire, a short parent questionnaire, which I'll show you momentarily. There are clinical interview guidelines published by Cheryl Masuna and colleagues in the Canadian Journal of Occupational Therapy. It doesn't mean that only occupational therapists can use these questions, so they are available for others. And finally, there's a listening for DCD checklist that might be useful in your practice as well. So the DCDQ is ask the parent 15 questions and to rate their child's ability on several daily activities, including catching and throwing a ball, cutting with scissors, riding a bike, ability to learn new motor skills, and so on. And from the parent's perspective, then the scores would indicate either definite DCD, suspected DCD, or probably not DCD. So this is often used in conjunction with the standardized motor assessment to determine if the child meets these criteria. The clinical interview guidelines, there's 3 broad questions, but the guidelines also provide you with specific probes under each activity. So, for example, what types of activities are difficult for your child? And you want to inquire about self-care, school, and leisure activities to see how the disorder may affect the broad domains of function. And are these difficulties that you've noticed for a while, or has anything changed? Really, with this type of question, you should hear some long-standing difficulties. It's not something that happens all of a sudden. So early in life, the child might be displaying some of these functional difficulties. And then finally, has there been a time when you've tried to teach your child something and it's taken longer than you think it should? And classic examples here are learning to tie shoes, learning to ride a bike, and And also with swimming lessons. In the clinic, we've joked that it could almost be a diagnostic criteria if the child's had to repeat the same level of swimming lessons over and over and over. So these are some useful guidelines to ask families about their child's development. And then finally, also available on the CanChild website is a Listening for DCD checklist. It's an interview guide, and it gives you a sense of whether these are a low, some, or a high concern to the parent and what the priorities might be related to their child's development. So those are a few tools for assessing criterion B. And then criterion C and D are really where we need the physician to assist for diagnosis. So the onset of symptoms is in the early developmental period. So this would come from your developmental history and developmental screening. And then finally that there's no other explanation for the child's motor difficulties. And this would be the neurological exam and other testing that may need to be done, as well as it used to be suggested that psychology assessments were required. But now the current recommendation is cognitive function doesn't necessarily need to be evaluated if there's a normal history of school academic achievement. But of course, as we heard earlier, children with DCD often have co-occurring learning difficulties and speech and language issues, so assessments by other team members such as the psychologist and SLP may also be valuable. And usually DCD is not diagnosed if there's a history of recent head trauma, any evidence of deterioration, if there's increased or fluctuating tone, if there's history of headaches or blurred vision, any asymmetry of tone or strength, any musculoskeletal abnormalities, or if there's a positive Gowers sign. I say this with caution in that there has been some cases where we have diagnosed DCD, but it's I would say the key word here is not usually diagnosed if these things are present. But I wanted to also give you some differential diagnoses just in case you're looking assessing children. So to consider any genetic abnormalities such as Down syndrome, neurological disorders such as cerebral palsy, any degenerative types of disorders such as brain tumors or muscular dystrophy, any musculoskeletal conditions, any physical or cognitive issues that may be at play, and any recent injuries such as a traumatic brain injury. One note of the cognitive, just want to point out that it is possible to diagnose a child with a mild intellectual impairment if the motor difficulties are significantly below their cognitive level, but it's very difficult to diagnose DCD in the presence of moderate to severe intellectual delay, as their motor skills are more in keeping with a global developmental delay. And then just wanted to note again that autism spectrum disorder is no longer an exclusionary diagnosis, and a child can have comorbid ASD and DCD. And just to end this section, I just wanted to provide you with some resources to assist with diagnosis. The first is an article that describes in detail the European Academy for Childhood Disability Guidelines for Management of DCD. There's an excellent article by Cheryl Masuna published over 10 years ago now, Why Every Office Needs a Tennis Ball, provides some strategies of what you can incorporate into your office. And then recently, my colleagues and I published in the Canadian Medical Association Journal an article to assist with diagnosis and management of DCD. And finally, on the CanChild website, there is a DCD physician workshop, which guides you through several steps in order to identify and diagnose these children. Now I'd like to switch gears a little bit and talk about some brain differences in children with DCD. And I have discussed this in previous talks, so I only highlighted a few areas here, but I'll give you some resources that you can refer to if you would like some more information. And really why I started down this path to look at brain differences of children with DCD was to determine why are they struggling to learn motor skills. and what is it in the brain that might be contributing to this difficulty. And if we found that there were brain difficulties, then maybe people would start to pay attention to this disorder. Because I think for the longstanding history is that this was just, a normal condition. We all can't be athletes or have impeccable handwriting, and that it's just a low end of normal. And in fact, what we've begun to show, myself and colleagues around the world, is that these children are neurobiologically different than typically developing peers. So it is a disorder in and of itself. It's not at the end of normal. So just to highlight a couple of neuroimaging studies, I conducted some of the first studies back in 2010 as part of my PhD, or that's when it was published. And the first showed that children with DCD, when performing a motor task, actually recruit more brain regions and different brain regions than typically developing children when performing a motor task. And this was published in Pediatrics, if you'd like to take a closer look at it. And really what this showed was they use a different network, which might not be as efficient when performing motor tasks. And more importantly, that they are working very hard to, they're recruiting twice as many brain regions. And if we think about this in the school day, the child has lots of potential, but the teacher may not be seeing it from this child. They know he's bright, but is either acting silly in class, trying to avoid activities, or they know that they're not reading the potential, so they might send the message that the child's not motivated, or they might be lazy, and if they just put a little bit more effort in, they could reach that potential. And this is where, if you think from the child's perspective, they're working twice as hard as the person beside them, but they get the message that they're not trying hard enough. And you can imagine what that would do to a child's self-esteem. So that's the first study. The second study we looked at was to look at motor learning in children with DCD, and with equivalent practice to typically developing children, and then what happens to the brain. And what we found was, first of all, that with equivalent practice, children with DCD did not improve their performance. So practice alone does not help these children. And what we also found is that they underactivated, relative to typically developing children, brain areas that are associated with motor learning. So this included some cerebellar, frontal, and parietal regions. And so this is the first indication that maybe there is something to the brain and their motor learning abilities. And then we looked at development of motor and sensory pathways. And this was just a small pilot study. And I'll just describe this one in a little bit more detail, as this really has informed other results I'm going to share with you. So we use a technique called diffusion tensor imaging. And really the purpose of this study was to examine the integrity of voluntary motor and sensory tracts in children with and without DCD. So we specifically looked at the cortical spinal tract, the main voluntary motor pathway, the posterior thalamic radiations, which is a main sensory pathway, and then we wanted to look at tracts to and from the cerebellum in the middle and superior cerebellar peduncles. And I'll just show you some nice color maps. These are the types of images we obtain from diffusion tensor imaging. And in the middle, we have the posterior limb of the internal capsule, which is where the cortical spinal tract travels. And then on the left, we have the cerebral peduncles, and on the right, the motor cortex. So we've selected these regions in order to track the cortical spinal tract and measure water diffusion in that pathway. Similarly, this was the posterior thalamic radiation, so looking at its pathway from the thalamus to the sensory motor cortex. And then we have the superior and middle cerebellar peduncles, which we also examined. Now I have to get technical here just for a moment so you can appreciate what the results mean, and another study I'm going to describe. With diffusion tensor imaging, we're basically measuring water diffusion in the brain along axons. And there's several different measures that we can obtain. The first one is called apparent diffusion coefficient, or ADC. And this is really measuring the magnitude, or how much water diffusion there is. A main measure that many studies report is fractional anisotropy. And what that is really the variance of these three directions, and gives us some sense of the relative direction of water diffusion. And then this is broken down into axial diffusivity, which is the long axis, the eigenvalue 1. And that's really water traveling parallel in the axon, so up and down an axon, whereas the other eigenvalues 2 and 3 are looking perpendicular to an axon. And this will become more apparent as I discuss some results. So the important thing to remember is axial diffusivity is water traveling along an axon. So don't worry about the numbers here too much, but I just wanted to share that we did not find any difference in fractional anisotropy, which is what is the main output that many studies report. And this likely was due to our small sample size, but we did find lower apparent diffusion coefficient, which means less water diffusion in motor and sensory pathways. We did not find such a finding in the cerebellar peduncles. So we wanted to look at this water diffusion. Was it primarily less in the axial direction, so along the axon, or perpendicular to the axon? And what we found was it was the axial diffusivity, so along the length of the axon, that was primarily affected. And so children with DCD had lower water diffusion along axons in both the cortical spinal tract and the posterior thalamic radiations. And this suggests that there's differences in either the internal characteristics of an axon or around the extracellular or extra-axonal space, as opposed to if we found water diffusion the opposite direction, it would suggest differences in myelination or glial cell morphology. So it was an interesting finding, but then you're probably saying, well, so what? What's the big deal? Well, in actual fact, this axial diffusivity, the water along in this case, the cortical spinal tract, significantly correlated with scores on the movement assessment battery for children. So in red, we have the children with DCD. In blue, we have typically developing children. And you can see on the y-axis, we have the axial diffusivity. So the children with DCD had lower water diffusion compared to the typically developing children. And this was a significant relationship. And we also found the same relationship in sensory pathways, and in fact, a stronger correlation here. So there seemed to be something with this axial diffusivity. And at the time of this study, not many people were reporting axial diffusivity. And so we thought maybe this was a spurious finding. We weren't sure it had any meaning. But in actual fact, we did find that lower axial diffusivity has been noted in some other white matter pathways in children with neurodevelopmental conditions such as autism and dyslexia. So there does seem to be something to these findings. So then we then decided to look at to further examine brain differences in children with DCD and also ADHD compared to typically developing children. And this study is currently underway, and we're comparing morphometry, or brain structure. We're looking at diffusion tensor imaging, so white matter pathways throughout the brain, and also functional connectivity at rest to further determine brain differences. And more importantly, as an occupational therapist, I'm interested to know if rehabilitation intervention can alter brain structure and function and improve motor outcomes. So we are doing a randomized control trial looking at brain imaging and motor outcomes of children receiving co-op intervention compared to a waitlist control group. And then finally, we want to know, after intervention, do these neuroplastic and functional changes remain at 3 months follow-up? So this is sort of my complex study design. I just wanted to highlight that it is a randomized controlled trial. So children with DCD and or ADHD, if they're randomized to the control group, would receive no intervention for 12 weeks. They'd have a brain scan and then would follow up a second brain scan 12 weeks later, and then introduce the intervention and scan again at time 3. If children are randomized to the treatment group, they would, after their first scan, go on to have 12 weeks of occupational therapy. 2 weeks of those are pre and post assessment and 10 intervention sessions. We'd rescan them at scan 2, and then this is the group that will follow up 3 months later. So we have doubled the number of children receiving intervention to increase power to look at those brain differences. Also, we are scanning a group of typically developing children and at the first time point, and also scanning them 24 weeks later to control for development. So we can then tease out whether the brain changes for those kids that received intervention are over and above what would be considered development over that time frame. So I'm very excited about these results, and it is underway, but I do have some preliminary data to show you. And these are brain differences in children with DCD compared to typically developing children. And we included attention as a covariate in these analyses. And you can see that we've got the green is the skeleton of pathways, so that's just the map that we use. But what you want to look at are the yellow and orange to red results, which indicates where the brain differs significantly between children with DCD and typically developing children. And in fact, they show lower fractional anisotropy, the relative direction of water diffusion in several brain areas, including the cortical spinal tract, which we would expect, the cerebellum, which we didn't find in our pilot work, but now that we have a larger sample size, we can see the cerebellum is implicated, as well as the fornix. In the middle, we have several pathways that are going through the posterior limb of the internal capsule, a bit of frontal area, the cerebral peduncle, and so on. And then finally, on the right-hand side, we have the splenium of the corpus callosum, which has been associated with motor skills, the anterior and posterior limb of the internal capsule, and other white matter pathways. So we can see we have a bit of frontal and temporal areas implicated as well. So we are just in the preliminary stages of analyzing these data, but in contrast to the first study where we selectively picked regions we were going to look at, this approach looks at differences throughout the brain, and we can see that there's some that are not related to motor skills that we'll take a closer look at. Then I just wanted to highlight some studies of my colleagues. So these studies were conducted by Dr. Deborah Dewey and her colleagues at the University of Calgary. So first they looked at the corpus callosum and showed that that fractional anisotropy, or the relative direction of diffusion, was lower in children with ADHD in the frontal regions, lower in the parietal regions in children with DCD, and those with comorbid diagnoses showed lower FA in both regions. So showing some implication of the corpus callosum here. They also, in another study, looked at cortical thickness and showed that children with co-occurring DCD and ADHD showed more widespread decreases in cortical thickness than with DCD or ADHD alone. And then they also looked at functional connectivity, particularly between M1, the main motor cortex, and brain regions associated with motor functioning and sensory motor processing. So they showed some commonalities between DCD and ADHD, as well as some unique differences between each group. So we have a bulk of evidence now showing multiple brain regions impacted. And just for, I could talk about brain differences for a whole entire talk, but just to point you to some review articles that might be beneficial if you're more interested in this area. My grad student and I completed a review of brain imaging studies that was published in 2015, and then we recently published neuroimaging and occupational therapy, how these findings can impact what we do as therapists. So I think it kind of brings the scientific, basic science evidence, if you like, back into the clinic and why it's meaningful. And then for the last few minutes, I'd just like to talk about the DCD clinic that we've established at Sunny Hill, and really why I wanted to establish this was I worked as a school-based therapist for many years and saw children with DCD on my caseload and felt that they were misunderstood, and every time I tried to advocate for a diagnosis, I would provide information to the family to provide to the family physician or the pediatrician, and the child either would not receive a diagnosis or I wouldn't know if they received one or not. And really, I think that the importance of the diagnosis is not necessarily to obtain funding at school, because depending on the school district, there may not be funds to support children with DCD, but I think the diagnosis helps provide understanding for people who are working with these children, so particularly teachers, coaches, physical education teachers, and so on. So I think it does provide a great deal of understanding, which then can be more supportive of the child, and hopefully they will receive more success experiences and less repeated failures in their daily life. So DCD is under-recognized and under-diagnosed, according to the European Academy of Childhood Disability. And in fact, others have surveyed physicians and pediatricians to realize that they were either unaware of the disorder, or if they were aware of the disorder, they were unsure of how to diagnose it. And really, this is because, as we talked earlier about the assessment, it is really a team approach to diagnosis. And so to address this gap, we established this diagnostic clinic, but also to serve now as a clinician scientist, a research database. So the primary purpose of the clinic is clinical, in the sense that we want to provide assessment by both a developmental pediatrician and an occupational therapist for consideration of a diagnosis, and we've limited the clinic to children 4 to 12 years of age. We also want to provide educational materials and recommendations to the child with DCD and his or her family. And one of the primary things that we often give our families is the parent workshop that is on the CanChild website. It's a very valuable resource for parents to learn about DCD and how they can support their child at home and in the community. The secondary purpose of the clinic was, as I said, to establish a research database and also to collect additional information from children and families who consented and assented to be included. And some of the things I'm looking at here are an IQ screen, attention difficulties, the psychosocial implications of DCD, and participation and quality of life. So we're collecting these data to answer some research questions, but really the main purpose of the database is to serve as a source of recruitment for current and future studies. So who do we see? As I mentioned, we see children 4 to 12 years for clinical assessment, but we're also interested in children who, between the ages of 4 and 18, who have already been diagnosed in the community, and they can be referred to the clinic for research purposes, so in which case they would be part of the database and complete those questionnaires. We include if there's a history of motor difficulties that affect activities of daily living or academic achievement. And at this point, we are accepting referrals from a family physician or pediatrician. However, due to the great success of this program, we may have to limit it to pediatrician referrals only. So just be cautious of that. We exclude children who have a history of conditions that may explain their motor difficulties, such as cerebral palsy, genetic syndromes, muscular dystrophy, and so on, or if they have a history of moderate to severe intellectual disability, as we discussed earlier. So we are an interdisciplinary clinic team of a developmental pediatrician and an occupational therapist, and we follow the European Academy of Childhood Disability Guidelines and the DSM-5 criteria for making the diagnosis. We do have a research associate that meets and greets the families and seeks to obtain their consent and assent to be part of the database. And we see two families simultaneously. So my physician colleague will see one family and I'll see the other. And we'll switch throughout the morning, and each of us will meet with one of the families at the end of the day to share the results and recommendations. Also, a key part of the clinic is that we have a trainee with each and every clinic. So these are trainees that are either in general pediatrics, developmental peds, pediatric neurology. We have had a family physician as well. So we are educating the next generation about DCD. So we do provide information for children and families. So in-clinic education, as I said, sharing the parent online workshop. We provide handouts also available on CanChild, and then specific recommendations for helping that child at home, at school, and in the community. So they leave the appointment with some information in hand and whether or not their child has a diagnosis. The research questionnaires that we are collecting include the DCDQ, the Connors 3 ADHD Index, the Strength and Difficulties Questionnaire, which looks at sort of psychosocial issues, participation and environment measure for children and youth, to look at how DCD may impact participation at home, at school, and in the community. We administer the Kid Screen 52, which is a quality of life measure, and then some family demographics. And just wanted to give you some up-to-date stats. The clinic opened in January 2014, and to date we have received 461 referrals. So this pleases me to no end that people are recognizing this disorder, and as evidenced by the number of referrals, we know these kids are out there, and the vast majority of referrals have come from community pediatricians, but we've also received tertiary team referrals from within Sunny Hill, family physicians, and then other pediatric specialists. So these include neonatologists, neurologists, and psychiatrists. And thus far, we've seen 169 children, and 89% of these families have consented to be part of the database. And we just have 125 kids entered in the database at the moment. And as you can see, 71% of those children received a DCD diagnosis. About 25 or 26% have had been diagnosed with other conditions. And some of these may be genetic, could be another neurodevelopmental disorder or some neurological condition. So it looks like DCD isn't always DCD, and so this comes through our developmental pediatrician's assessment. And then you can see we also have a provisional, sorry about the typo there, provisional diagnosis, and this is where, for all intents and purposes, it seems like the child has a diagnosis, but we are waiting for test results either for genetic testing or a neurology assessment or some other assessment. So if that is negative, then we presume the child has DCD. So we do provide a provisional diagnosis until pending further medical testing results. And then just to give you a sense of who we have seen, so of those 125, 89 have a confirmed diagnosis of DCD. And as you can see, the vast majority are male, 83%. Average age is about 8. And they are performing quite low in the movement ABC, so about the 3rd percentile. So you can see that's it's rare that we use that less than 16th, but it does happen. In the DCDQ, the vast majority are in the suspected or indicative range, and you can see that the kids are of average IQ. So just to summarize, our interdisciplinary clinic model is streamlined to fill a critical gap in providing diagnosis and recommendations. And importantly, we are educating the next generation of family physicians, pediatricians, and subspecialty fellows about DCD so that we can no longer describe DCD as under-recognized. And that, very exciting, the vast majority of families have consented to be part of the research database. So there is an interest of families to do this. We have also I've helped to facilitate a BC DCD parent support group. So I've had one parent step forward and wanted to create they have a Facebook group and also meet in person sometimes. And so we have a support group that has stemmed out of this clinic as well, which is very exciting. Okay. Oops. And then future directions, we feel that this model serves, or the clinic serves as a model for establishing similar clinics of those that might be interested in doing so, and offers the potential for national and international collaborations for systematic data collection to increase our collective understanding of and service for children with DCD. And then just to wrap up so that we have time for questions, I hope that by this talk you understand that DCD is a chronic health condition that's under-recognized and under-diagnosed, but we're trying to address this gap through the DCD clinic and through educational avenues such as CAPC for physicians and therapists. Brain imaging studies are beginning to shed some light on why children with DCD struggle to learn motor skills, and that with our ongoing studies, we may inform how rehabilitation changes the brain structure and function in these children, and hopefully improve motor outcomes. I just want to thank my research team. Just like it takes a village to raise a child, it takes a village to support a PI in the research program, a team at BC Children's Hospital, at Sunny Hill, my trainees, and of course my sources of funding. So with that, I'd like to thank you for listening, and I'm happy to take questions.
All right, thank you very much for a great presentation, and we do have quite a few questions, so I'm not making any promises that we will get through the entire list, but we might as well get started. The first question was just around, it came on quite early, and you sort of made some mention of some of this, but just the process, at least in your clinic, and then maybe we can hear from Gail, if we can actually hear Gail. We haven't heard her voice yet, so hopefully she's actually been connected. She said she was, but the question is around if you're an OT or a PT during a visit and you suspect DCD, how do you go about? What's the process to getting a medical diagnosis of DCD? And maybe just in your area, Jill, like as far as the step from suspicion to diagnosis, et cetera. And then maybe we can hear from Gail just as far as maybe a center that doesn't have as well of an established DCD clinic as you have. So maybe just give a sense of the process of getting to diagnosis. Sure.
Well, I think usually it's the therapist might see the child first, and I would suggest doing an assessment like the Movement Assessment Battery for Children, and if possible, the DCDQ, and then giving that information to the family and or with their consent, sending it to their physician with to consider a DCD diagnosis. And there is a handout on the CanChild website that would be useful to include for physicians. So between your report with those findings and a little bit of information about what DCD is, in case the physician isn't aware of the disorder, basically gives them the criterion A and B information, and then the physician can then look at criterion C and D. So this is what I found wasn't happening when I did that. It was several years ago now, so things may have changed, and with physicians more aware of the disorder and the DSM-5. But I think as therapists, we can provide the information that the physician needs in order to make the diagnosis.
And Gail, can you hear us?
Yes, I can hear. Can you hear me?
Yes, we can. All right.
Oh,
so maybe
great.
So what does it look like in Edmonton, at least, for going from suspicion or screening to diagnosis?
Well, I really like Jill's whole approach, and I think one of the key messages is increasing awareness of what DCD is. Needs to really be brought to the forefront in physician education and training, and also within the educational system, and because of the social skills in the mental health system. So we have a lot of training to do to first get that awareness that this could be DCD. We don't at the Glen Rose Rehabilitation Hospital have a formal DCD clinic or team, but we do make the diagnoses because we have a multidisciplinary team approach to all developmental conditions. So it's really a partnership with the occupational therapist or physical therapist and the physician on the team. And I think the physician's role really is that differential diagnosis that Jill mentioned, looking at, could this be another condition? Is it something we need to pursue with genetic testing or other looking at muscles in more detail. So I think we have pockets of good practice, but we certainly don't have across the country, except for BC and maybe at CanChild, that really organized approach. And after diagnosis, of course, there's where do we go for interventions?
All right. Now that we can hear you, Gail, just feel free to jump in with any questions that you might have. We do have a number of questions that are sort of on a similar theme, Jill, just around sort of sifting through other potential conflicting and interfering conditions and diagnoses that make it difficult to diagnose. So, for example, Shannon's saying, should DCD be diagnosed in children with FASD or Tourette's, or do these neurological conditions explain their motor deficits? And just another one, just before you answer that, I'll just read this other question. It's sort of similar. She's saying, my understanding is that a DCD diagnosis can't be made if another neurological condition that affects movement was already diagnosed, such as cerebral palsy. She was wondering, knowing that a large number of preemies have had hemorrhages affecting the brain after birth, if the diagnosis of encephalopathy could prevent a DCD diagnosis like CP would. This seems to be interpreted differently by different healthcare providers that she has discussed DCD with, and she'd just greatly appreciate your insight. So just in general, that sort of theme of how do you sort of sift through other conditions and identify a DCD diagnosis.
Right. Those are excellent comments. And I'll deal with the preemie question first. So certainly in our clinic, we do have a partnership with BC Women's Hospital and the neonatal follow-up program, sending kids our way who they have identified with DCD at 4.5, and that will follow as a continuum of care. So for children who, if they have intraventricular hemorrhage, say grade 1 or 2, that's not so much of an issue, but if they have grade 3 or 4, that becomes an issue and more likely the explanation for their motor difficulties, but it is a gray area. Similarly with white matter injury that might be associated with cerebral palsy, for instance, if there's frank white matter injury, then it's definitely harder to make a DCD diagnosis. So preemies are unique in the sense that they are much higher risk, but they also are at higher risk of other neurodevelopmental conditions. So what I'm hoping is that in our current study where we're looking at brain biomarkers in the neonatal period and DCD and other conditions such as cerebral palsy, what are the brain differences between those two conditions? And hopefully we'll be able to tease that out and provide some more direction around those vague areas, the IVH 1 and 2 and so on. In terms of other diagnoses, so definitely cerebral, if the child has cerebral palsy, they do not have DCD. So those are mutually exclusive. Some people would argue that DCD and CP is a continuum. So I personally disagree with that in the sense that as a therapist, I can tell the difference by looking and feeling a child with CP versus DCD and which is which. But I can appreciate that some of the same predictors may be involved. So again, hopefully our research will help tease that out. In terms of FASD and Tourette's and so on, the DSM-5 does allow a comorbid diagnosis if the motor difficulties are over and above what you would expect. So FASD, my understanding is that their motor difficulties are not necessarily part of the diagnostic criteria for that disorder. So if you do have motor difficulties that are over and above what you would expect, then a comorbid DCD diagnosis is permissible. Obviously, it's a little bit more complicated with children with these other disorders, and so that's even more so why it's important to have a physician assess and confer on the diagnosis.
Doug, it's Gail. Could I comment on the fetal alcohol spectrum disorder? Because I am also medical director of the Glenrose FASD clinic, and part of the Canadian researchers looking at all aspects of FASD. With the criteria in 2015, the new Canadian guidelines for the diagnosis of FASD, motor is one of the domains, one of the 10 domains that we are considering. Very often, motor is a relative strength in FASD, which we can then build on in terms of our intervention plan. But when we do see motor difficulties, it's often very significant and certainly limiting in terms of written output and participation in community sports, which then interferes with social development and social opportunities. So we do see it is significant. We do actually rank it as one of our diagnostic criteria, but we also will make a diagnosis of DCD if the DCD criteria are also met. And then we try to get interventions put in place. When we look at the literature in FASD and DCD, there's quite limited. There's been some new interest in DCD and autism in the literature. And even in motor skills in FASD, it's almost a kind of a bit of a frontier area of exploration. There's a few articles recently from the Australian group, so an opportunity for research.
That's great, Gail. Thank you.
All right. The next group of a couple of questions are sort of around the cognitive issues that a lot of people are sort of associate with DCD as well, or see in conjunction with. So I'll just read, there's two questions in particular. The first one says, do children with DCD tend to have difficulties organizing, for example, keeping their desks organized or their rooms tidy, etc., that sort of thing? The other person's question was similar. It says, again, anecdotally, they see a lot of difficulty with ideation, organization, and sequencing, not just with motor-based tasks, but also in more abstract play and problem-solving. And they go on to ask, what, if any, patterns of cognitive challenges have you seen associated with DCD? And you sort of mentioned some of those associated cognitive issues, but maybe you could expand a little bit more on that.
Right. So this is a subject of recent investigation. Again, some may argue that those organizational difficulties might be more in keeping with a co-occurring diagnosis of ADHD, for instance. But there's some work by Peter Wilson in Australia looking at executive functions in DCD. So there is some indication that children with DCD do struggle with sort of organizational tasks, executive functions, and so on. So I guess it's still it's still yet to be determined what is actually DCD versus a comorbid condition, but certainly I hear that a lot in clinic, and certainly when I saw children in the school system.
We do have a number of parents in the audience, all very expressing comments, expressing their appreciation for this conversation and the opportunity to learn about this a bit more. One has asked, has commented that her 8-year-old son has been diagnosed with DCD and SLD in written expression. And maybe you can explain for the audience what SLD means. I'm not exactly sure. I'm assuming it's some sort of learning disability in written expression. And she says, we were having trouble determining whether ADHD is also present. The Connors 3 indicated yes, the combined type, and the SNAP-4 indicated no. Again, just sort of this issue of DCD in conjunction with other things, in this case ADHD. Just wondering what steps they can take to get an accurate diagnosis either way. Right.
Great question, and I'm thrilled that there's parents in the audience as well. So thank you for being here. So the issue with ADHD, so you've got a 50-50 chance basically that your child may also have ADHD. And what really strikes me, especially in the clinic, is performance across different tasks. So for instance, we may have a child come in who has suspected ADHD and query DCD. If I do the motor task, I can see the attentional difficulties compounding the motor problems. But then if I give them a cognitive task, so that when I'm screening for IQ, for instance, all of a sudden they're sitting still, they attend, there's no silly behavior, and so on. And so really it's looking at performance in different environments on different types of tasks. And children with DCD often have, a greater likelihood of having difficulties with attention than typically developing peers, not necessarily moving on to a clinical diagnosis of ADHD. So attentional difficulties are very common. Whether or not the diagnosis is warranted is another question. And so usually what happens for ADHD is that there's multiple questionnaires, not only by yourself, but also say the school teacher, maybe the gym teacher. So seeing the child in different environments and collecting data in that respect. But I would suspect that attention may be an issue regardless of the diagnosis, and if there's strategies in place to help support your child with that, wouldn't be a bad thing.
From a developmental pediatric perspective, often when ADHD is very evident, it masks and nobody considers the diagnosis of DCD. So that's the corollary. We should, keep that, a comorbid diagnosis concept open.
All right, and we are pretty much out of time. So there is one more sort of group of questions that I'll just sort of combine into one, and we'll just call that our last question. Unfortunately, there is quite a list of questions. Unfortunately, we won't be able to get to. And then maybe we'll hand it back over to Gail and Jill for any last sort of closing comments that you'd like to end off with the audience and leave the audience with. But these last couple of questions are around sort of that 0 to 4 population. Your clinic, you said you start at age 4, and one person was just asking why that is. Another person is asking about taking a developmental history. Can you speak to any trends in the birth to 3 or birth to 4 population? For instance, on a toddler sensory processing questionnaire, or do you find that a sensory processing disorder could be identified early on? So that 0 to 4 population, is there any indication that there would be an opportunity to diagnose this any earlier than 4?
So this is emerging. So the current guidelines for the European guidelines say a diagnosis shouldn't be made before the age of 5. So that's what the current literature suggests, and that was published in 2012. However, we've looked at motor performance of children who are at high risk, so preterm born children, and those children scored significantly poor on every motor test, whether that's the movement assessment of infants, the Bailey-3, the Peabody, scored significantly lower than children who didn't develop DCD. So there are some early signs, if you like, of motor performance in those early assessments. So my advice would be if a child is showing any sort of motor difficulty at those younger ages, those children need to be monitored, whether that's follow up again or see a pediatrician, just to be monitored. And the parents report, depending if they're first-time parents, may not realize what should be expected of their child at that age, but it's again more in motor learning difficulties. So they may meet their developmental milestones on time. Some may not, but milestones is not the criteria. So if they have normal milestones, it doesn't mean you don't follow them. It's more the quality of movement and if there's motor learning difficulties. So in that early population, we've shown say if a child was assessed at 3 on the movement assessment battery for children, how well does that predict diagnosis at school age? And in fact, there is a lot of false positives at age 3, but if a child scores in the normal range, those kids do not go on to develop DCD. But if they're in that borderline range, some of those children certainly will. So if there's any indication of early motor difficulties, don't assume that the child's going to outgrow it, I guess is my message, and continue to monitor their development.
All right. And I think with that, we will have to wrap it up. We'll come back to you in just a second, Jill. But Gail, any last questions or comments you'd like to ask Jill, or just leave any comments you'd like to leave the audience with?
Well, I just want to thank Jill for this fabulous presentation. Just, I think, increasing awareness of this condition that has really not been recognized is so important. But we also then, as we increase awareness, we need to build DCD clinics or assessment capacity, and then we need to learn from Jill what are the best interventions that we can help, perhaps with improved brain plasticity and improved function. So we're looking towards your future research, Jill, and implementing it into practice.
Thank you, Gail, and thank you for all of those that joined in today. I really appreciate your attendance, and I'm thrilled that DCD is getting some much needed press and awareness. So, thank you for the parents that joined as well.
All right. And what would be the best, for those who do have, like I said, there are quite a few questions that we were not able to get to, a lot specific around interventions and what do you do and that sort of thing, like specific into the intervention. So if people were looking to get in touch with you, or the best place to find out more information about that sort of thing, where should people go? So,
well, two things. My email, which I might not be able to get to right away, but my email is jill.zwicker@ubc.ca. And also I direct people to the CanChild website that has a wealth of information about DCD. It has workshops for parents, for physical therapists, for physicians, handouts for teachers, and so on. So CanChild certainly has the mark for knowledge translation and information about DCD. But if you have specific questions, feel free to email me, and I'll do my best to answer.
All right. Well, thank you very much. Like Gail said, a fantastic presentation, and really a topic that, like you said, maybe not under-recognized anymore. Lots of people interested in it, and interested in how we can, as Gail said, build capacity in diagnosis and intervention, and then, as you were mentioning, in research, and really trying to understand how best to address this problem going forward and help these children. All right, so we do our webinars every Wednesday at 11 a.m. Eastern Time, and as you can see, it's great when you can watch live, as sometimes we get to your questions. When there's this many questions, unfortunately, we can't, but we do get to, at least when you watch live, you get to participate in the discussion. And when you can't watch live, we do record these sessions and make them available after the fact on the Knowledge Exchange Network. Next week, on March 8th, it will be Playtime, with a session that's called It's Playtime, Unexpected Reasons Why Physical Activity is So Important for Kids. We'll be hearing from Dr. Patricia Longmuir from the Healthy Active Living and Obesity Research Group, the HALO group, at CHEO, the Children's Hospital of Eastern Ontario Research Institute in Ottawa, where she will be talking about how we all know that physical activity is important for physical and mental health, but at this presentation we're going to hear how active play is also essential for childhood growth, development, and a good quality of life. The webinar will review the evidence supporting the importance of childhood physical activity in pediatric healthcare and its potential for treatment, as well as primary and secondary prevention, as well as tips for assessing childhood physical activity and supporting parents to become more involved will also be provided. Then following that, on March 22nd, we'll be hearing about pediatric donation, organ donation, after circulatory determination of death, development and implementation of Canadian guidelines. We're going to be hearing from Dr. Matthew Weiss, a pediatric intensivist working in Quebec City at the Centre Hospitalier Universitaire de Quebec, and Amber Appleby, who is the Associate Director of Deceased Donation and Transplantation at Canadian Blood Services. And they're going to help us understand the process that's been used to develop a set of national clinical practice guidelines around the donation of organ donation after circulatory determination of death, which is different than donation after brain death. And they're going to talk about, this will be an opportunity for a discussion with Canadian experts in the area of pediatric deceased donation in general. So it'll be an interesting and somewhat controversial topic, and that's in 2 weeks on March 22nd. So hopefully we've got such great topics coming up in the next couple of weeks. We hope that many of you will be able to join us at some of those presentations coming up. So thanks again for joining us today, and we'll see you back here next week, hopefully. All right, bye, everyone.